Ma'am, please start.
Good evening, everyone. It's my pleasure to welcome you all to today's webinar organized under the Outreach subsection of the Indian Academy of Neurology. We are honored to have two distinguished speakers with us today. Dr. K. Madan Gopal. He's a highly respected figure in public health and currently serving as the advisor and head of the Public Health Administration Division at the National Health System Resource Center, Ministry of Health and Family Welfare, Government of India. Dr. Gopal has played a pivotal role in shaping health policies and strengthening healthcare delivery systems across the country. He is a senior consultant at the Niti Aayog. Dr. Gopal also plays a pivotal role in creating and advancing the State Health Index, spearheading its development for 5 editions to drive competitive federalism and improve the health system performance across the states. He has contributed significantly to flagship initiatives, including the Aspirational District Program, District Hospital Rankings, the National Digital Health Mission, and the Ayushman Bharat PMJ. Implemented the Rashtriya Swasthya Bima Yojana and leads the state-level health governance reforms, capacity building, and evidence-based policy making. We're privileged to have you here, and we look forward to your speech and take away from there. Our second speaker is Dr. Ramani. He's a neurologist at the Raffles Neuroscience Center. Dr. Ramani is importantly, he is the adjunct professor at the Department of Medicine, Yong Lu Lin School of Medicine, National University of Singapore. Dr. Ramani, he completed his MBBS, Masters of Medicine, and fellowship with the Royal College of Physicians, Edinburgh. His other qualifications are the Fellow Academy of Medicine, Singapore at Neurology, Certified Neurosonology, WFN Neurosonology Research Group, and American Society of Neuroimaging, Masters of Science, Epidemiology, London, and Masters of Health Science, Stroke Management, Newcastle. He's the founding and current chairman, Asian Stroke Advisory Panel, and founding member and current advisory board member, Singapore National Stroke Association, Singapore National Level Stroke Support Group. He's editorial board member of many peer-reviewed journalists. His publications and research interests are in stroke, neurosonology, dementia, and neuroepidemiology, and he's currently the president at the Asia Pacific Stroke Organization. So we're going to have another 1 hour deliberation from these two eminent speakers, and everybody can write down their questions in the chat box, and we will take the questions after each talk. Dr. Madan Gopal, we look forward for your first talk.
Thank you, Bindu, for giving me this opportunity to share my perspectives. Hello, good afternoon, everybody. Let me share my presentation before I start. I think my slides are visible.
Yes, sir.
If it isn't slideshow, okay, that's fine. Okay, that's fine. Good morning, good afternoon. Bindu, I would be just talking from the policy's perspective. That is how we are doing in the neurological space. So we do have a national mental health program, and the neurological aspects are there, a part and parcel of that program. But it's more or less focused on the mental aspect, not on the neurological aspect. So let us see that what are the evidences which are available and how the synthesis can act for a strategic action and other things. As I mentioned that with the aging population, currently the aging population of the country is around 13% of the population, roughly 13 crores. See that in the coming years, as the census results are out, you see that how this aging cohort is increasing. And by 2030 and 2047, this would be comprising 15 to 18% of the population. See that this is a very sizable, given the numbers, it's a very sizable population, and invariably with aging, with regeneration, you would be having mental as well as the neurological problems. Neurological disorders are the major and increasing public health issue, which is contributing to 12% of the total disease burden. 10% is not a small number, but it's a very big number. And we are seeing a significant epidemiological shift. Non-communicable disease burden has doubled from for the last 3 decades. It has doubled, while the communicable disease burden has decreased. But still, India is having the triple burden, which we commonly call the evergreen burden of the reproductive child health. The other is the communicable disease, and the third is the non-communicable disease. In the non-communicable disease, the portion of this mental and the brain health issues that is also increasing in the coming year. And with the aging population, I think the kind of burden which is going to be there on the system, that is quite apparent, and we are slowly and slowly gearing up to address this aspect as well. Then as a result, what happened, as I mentioned and been emphasizing, that we require a focused policy attention and a robust governance mechanism to address this condition. Because if we don't plan now, then in future it would be just a knee-jerk reaction to the situation which arises. That's why all the plannings and other things are happening. As I mentioned, that stroke is the leading contributor of neurological dailies, disability-adjusted life years. The third leading cause of death in India. Apart from that, the headache, which is very common contributor, is often neglected. We often neglect the headache. Headache is a headache for a physician or for anybody, but we commonly neglect it. But this is the second largest contributor to the deaths. The epilepsy, the third largest contributor. Then dementia, significant contributor to daily faster growing disease burden. As the population ages, you see what kind of burden which we are sitting and what kind of thing which we have to plan. The Parkinson's disease also growing prevalence is there, and it is contributing 1.8 to the Delhi. The key risk factors are the high BP, the air pollution, diet, high sugar, and high BMI. All problems are there. We are a population of 1.4 billion, and if you see, even our highest leadership is saying that we should be reducing the sugar and the salt content in our diet. We should be reducing our oil content in the diet, because that kind of perception is also certain at the highest level of thinking, saying that unless you address the risk factors, whatever facilities you create in the country, that would be not sufficient to cater to the needs of the population. But if you look at the state level variations also, there is a significant disparities in neurological burdens across Indian states. Example, the two daily variation in West Bengal, you look, the stroke is 5.5 times more, highest in West Bengal. When you come to the epilepsy side, Odisha is having 4.4, 2.4 times more than rest of the states. The headache disorders, there is a minimum variation across the state. This reflects the differences in the risk factors, health system capacity, socioeconomic development, policy implementation. But nevertheless, it also necessitates that whatever planning which we do at the policy level, it has to be state-specific problem, state-specific interventions, and tailored to the local requirement. What happens is, if I am planning something for the south and want to replicate the same thing in the north, this is not going to happen, because the state-specific requirements would be different, and we have to always focus on a tailored intervention for these things. Apart from that, if you look at the number of neurologists, how many neurologists we require? Right now, the ratio is 1 neurologist per million population. We require at least 20x number of neurologists in the coming years to cater to the need of the population. When I was in Niti Aayog, when we were doing the projections, I was pushing for the DNB route for the post-graduation training. At that time, we have factored out how many number of doctors are there. And you see that that's why at the highest level also, they have been pushed for increasing the postgraduate seats. The neurosurgeon using 1 per 375. This is the current situation, and we require at least 10x number of neurosurgeons, which is far below the WHO recommendation for general health workers. But don't talk about the WHO. But once we are having a vision for having a Viksit Bharat 2047, in a Viksit Bharat, you have to see that whatever ailments, because the communicable disease will go down, non-communicable disease will be there. The RCH, you are already going to take care of that. But are we adequately prepared for that? Do you have adequate number of neurologists and the neurophysicians for that? So that we have to prepare. This is a serious shortage. We have to address that. Medical college, the rate at which we are churning out the neurologists and the neurosurgeon, it will take another 3-4 decades to address the gaps which gap of the people who are required as of date. Compounded with that, you do have a urban-rural divide. 80% of the specialists, they are located in urban areas or they would be practicing in peri-urban areas, and sometimes in a satellite mode, they would be now, with the advent of the teleconsultation, they would be working in a hub and spoke model. But that is not going to suffice, because if you look at the kind of requirement which is there, if I hold a video camera in a different angle, the diagnosis will differ. So that kind of challenges which we are having, so this, how to address this urban-rural divide, that's another thing. And if you look at the percentage, how many neurologists they are providing the urban area, 2.7% population is only served by this neurologist. And maximum 68% of the population lives in rural areas. We do have a network of around 2,10,000 health institutions, 1,70,000 health and wellness center of the Ayushman Arogya Mandir, which are supposed to take care of the mental, dental, and the other services apart from the RCS services. But how to connect these people, they are the outreach people, with the neurologists, so that whatever specialized care, whatever specialized consultation or the counseling which needs to happen, that can happen at this level. When we have having a vast geographic area to cover. But we are focusing and investing into the training, building capacities, task shifting the training of the neurological condition to the medical officers in the public health system, because we can't be waiting the private sector to take over whatever system we have evolved over the last many years, 210,000 facilities. We are trying to build capacity into these facilities so that we can meet the demand which is there. But still, it is insufficient to meet the current demand, which I have already mentioned about. If we talk about the infrastructure and the diagnostics, we do have Indian Public Health Standard, which talks about 12 specialist services, including neurological services at a district hospital. And India is having a federated architecture. You have states, sub-districts. States are having districts, sub-districts, and blocks. Below the blocks are the sector headquarters and the Ayushman Arogya Mandirs. We have to see that how the specialized neurological facilities which are concentrated into the urban areas, how we can extend the services to the rural areas. That barrier we have to overcome. Besides that, rural population face long distance travel, which delays critical stroke for this. To address that thing also, what we have been doing in the government is we do have a emergency medical response initiative as well as mobile medical units. But we can't be everywhere. So 108 ambulances, 104 ambulances, or any other emergency medical response, we are supporting around 30,000 ambulances across the country to address the long distance travel and the emergencies because of the stroke and the neurological emergencies. Besides that, if you talk about the MRI and the CT diagnostics, most of the district hospitals now they have the CT scan facilities. But as the district hospitals are getting upgraded into medical colleges, now you will be having MRI facilities at the district level. Having said this, even if I am extending the MRI facilities at the district level, do we have enough neurologists to cover and cater to the requirement? If something has been diagnosed, if without a neurologist or a neurosurgeon, what are you going to do after that? That's a problem. That's a question which we are asking, and we are trying to find solutions. Though on the lines of the uh, uh, comprehensive medical obstetric care and the life-saving anesthetic skill, the task shifting which courses which we are having. We are also contemplating task shifting for the emergency in the critical care in this area. Then we have identified 29 conditions, and the National Life-Saving, the National NELS program, National Life Emergency Skills, that program is also there. We're trying to address this issue through this. Besides that, rehabilitation services are important through the community health officers who are located at the Ayushman Arogya Health and Wellness Center. We are trying to see that how the services are rehabilitated. Now, if you look at the primary health centers and the community health centers, you do have a physiotherapist there. That the rehabilitation services, we're trying to focus on that, see that services reaches there. Besides that, the Ayushman Arogya Mandir, we do have a wellness component to that, in which the yoga and therapists, that kind of physical exercise are being promoted there. Besides the house to house visit by the ASHA workers for addressing the rehabilitation part. But for this neurological and the tertiary level high-end services, there is an excessive reliance on the private sector, which raises the equity concern. Where will the poor people go? So that's a concern we have to have, and Dr. Bindu is doing an excellent job in addressing this concern. So, how the equity concerns which have been raised and flagged at our level, she is doing an excellent job in addressing these concerns. And the national policy, we do have a national policy which talks about all these things. The national health policy, which was enacted in 2017, it focused on preventive promotive health and acknowledging the non-communicable disease burden. As I mentioned in my previous slide, that the main problem is in the coming years would be non-communicable disease along with the burden of the RCH. He said, are we equipped or not? Besides this neurological disorder, because the aging population is there, non-communicable disease there, the risk factors are there, BP, blood sugar, the high blood pressure. These problems are there. The aging population is there, and the lifestyle. Because if you talk about the aging population, we can't be taking the typical the senior population in 60. We have to see that the person who's 55 and above, he should be considered as a senior population, and we have to focus providing services from that age group bracket onwards. We do have a national program for non-communicable disease, which primarily focuses on major non-communicable disease, including strokes. We support the non-communicable disease clinics at the district CSCs, as well as screening and diagnostics at the Ayushman Arogya Mandir, that is at a population of 5,000 population. Besides, as I've been talking about the Ayushman Arogya Mandir, previously it was sub-health centers. We were rechristened as health and wellness center because we have moved from disease to wellness, wellness to well-being. So in that in that flow, we are trying to now see that this Ayushman Arogya Mandir, they become a place where we provide assured 12 comprehensive healthcare packages, including screening for non-communicable disease, mental services, and management of these cases. Because a question will always arise that how you are managing when the CHO is not a medical doctor. She's a trained BSc nursing staff, and based on the telemedicine and the e-Sanjeevani program which we are having, she's gets connected to the higher centers at district hospital, medical colleges, and the services are being provided, and she can prescribe drugs. Drugs are available at the Ayushman Arogya Mandir based on the prescription of uh, the the hub center. The medicine, if it is available, is given. Otherwise, the person is sent to the higher reference center, and the medicines can take. Besides that, for the providing secondary care to address the catastrophe due to illnesses, we do have Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. This is the largest health assurance program in the world, catering to around 700 billion population. If you add to the state-sponsored health insurance schemes also, the number would be around 80 crores or 800 millions. In this also, neurological conditions are covered, epilepsy is covered, plus, in fact, the mental conditions are also included. When I was designing this HBO1 package, the mental conditions are also included in this package. So this package is there. We see that how the private sector, how the people who are eligible for availing treatment under this, they can also get treatment covered in this. Essentially, what we are assuring in this program is providing a 5 lakh per family cover per year has been given. And so far, we have been able to, if you look at the numbers, it's around 60,000 crore savings have happened because of this program. If you took over these are the, now we can talk about how the governance of this can happen. We do have two mechanisms. One is regulatory bodies with the National Medical Commission is there, and the Clinical Establishment Act is there. We have two governing regulatory bodies which are there, but more or less the Clinical Establishment Act, which happened in 2011. After that, the uptake has not been up to the expectation, because many of the states, they have not enacted and adopted or adopted this act. At the central level, for any health policy, the central government is the central authority, and it coordinates, because we do have a federated structure. It coordinates with all the states for implementation activities. Besides that, for undertaking research activities, these are the central government sponsored health institution, ICMR, NSHRC, NIMHANS, the NITI Aayog. These are all the organizations which, right from the policy level research to the implementation research, they focus on in bringing out things. Apart from that, The implementation lies with the state government. We see that how the state health departments they strengthen the system and see that the whatever activities, policies, and the other thing which have been agreed with the central government, they have been implemented. If you look at the other way, as I'm just elaborating further on this, what that the ministry does the policy formulation, as you have seen, the National Health Policy 2017, the Ayushman Bharat, the four pillars, the national programs like the National Health Mission, the National Program for Non-Communicable Disease, the standards for this, the funding to the states, the National Health Authority, the implementation agency for PMJ, as the state responsible for uh, the healthcare delivery, infrastructure management, workforce, program implementation. As in the Constitution, health is the state subject. But the regulatory bodies also, you see that the variable enforcement is happening. I just reinforcing this fact, which I have mentioned in that how things are happening. So we do have all the landscape which is required for supporting the uptake of these neurological services. But if you take the example of the National Mental Program, which includes the neurological disorders, but we have more or less, they only talk about the mental ailments, but not about the neurological things. We have to see that as a association, we have to see that how we take the neurological aspect and make more guidelines and more activities are being included in that mental health program. We see that how we can do that because that's already there. Brain health is already there, but it's increasing focus is on the mental health. But you look at the critical challenges. The critical challenges is the data. One of the critical challenges in any of the government scheme is the data. The data for surveillance, because unless and until we have data, what kind of intelligence we can build? The daily and other things, they are all estimates. How we can calculate the daily, how we can calculate the morbidities, how we can calculate what interventions we are doing and what direction we are moving. So we are trying to increasingly focus on the monitoring, evaluation, learning, and the research aspects. That is also been there, but we have to invest more into that. As a result, you have seen when the government is moving towards the Viksit Bharat, their Anusandhan Foundation has been created, wherein 1 lakh crore has been earmarked for carrying out research activities. We see that in the coming days, you will be seeing more and more about the research. Besides that, you see about the quality of care, maintaining high standards of quality care. We do have two programs, Indian Public Health Standards, which envisage to have a minimum standards for providing minimum level of services. Talk about how many neurologists are required at the district hospital, that number is there. What he will do, that is there. The responsibilities are there. Besides that, the financial constraints which are there, that enabling mechanism is there. It depends on the spending capacity of the state. Because if I spend more this year, I will get more next year. Because every year, whatever you have spent, it is 5%, 10% more is added based on their spending capacity. It's not that I can be, it is very easy to say that the government should be spending 2.5%. We have reached 1.9% of the spending. But depending on the spending, some of the if you look at the revised budget estimates, usually it is around 80% of what government is allocated. But we are building capacities to improve the funding capacities for expending more so that more funds can be released. Other barriers is there, critical challenge, overcoming barriers in implementation of non-communicable disease. Because we require a scientific evidence for this, as I mentioned, the data and surveillance aspects is required. How many patients are going in the private sector getting treatment for neurological disorder? We don't know. We do have some market surveillance from the Department of Pharmaceuticals. How many these drugs which are required for neurological conditions they have been used. But number of patients when they are coming into the system, health system, the public system, we do have the data. But many people there, as the private offers a more sophisticated kind of treatment, so they go there. That number is not available. Then the other focus is on improving the access to healthcare. We have invested a lot, and if you talk about the Ayushman Bharat Health Infrastructure Mission, wherein around 70,000 crores have been given for improving the health infrastructure in the country. That's the largest investment which can happen during the post-COVID times. And work is in progress, and in coming years, you will see that around 2 lakh more beds would be added into the public system. Right now, public health system is contributing to 65% of the bed capacity in the country. And adding 2 lakh more beds, you will see that what would be the number. We are having around 14 lakh beds, of which around 8, 9 lakhs in the public sector. And 2 more lakhs beds should be added. So that number is coming. Then, if you look at the other critical challenges, is you see that we have always been talking about the underfunding of the public health system. Is there? But underfunding, you have to find out the reasons for underfunding. See that if the capacities for expending the money is there, then obviously you will have more funds available in this. If you talk to any of the government functionaries, they will say that funds is not a problem. The problem is the capacity to spend that fund in the prescribed financial discipline and other things. The other thing is the health expenditure which is happening. The behavior of the health expenditure is changing now, and we see that more and more people are getting aware, and they're getting themselves treated as early as possible. The Pradhan Mantri Jan Arogya Yojana, you see how it has been a game changer in the landscape of the health system in the country. More and more people now availing it, around 80 crore people roughly. If you include the state sponsor health insurances also, they are covered by one form or other. Their behavior has changed. They are all thronging and getting themselves treated, examined, so that whatever things are there, early diagnosis happens as early as possible, so that the rehabilitation, other measures are also instituted there. We are trying to address, that's an area, the urban rural divide, an area we are still working on evolving urban framework for health. So my division is working on that. We see that we are not being able to do much in the urban space, but many models are there in urban area, and we will find a solution for that. Besides that, another critical challenge which we are having is the language literacy, gender norms, and the stigma associated with the mental conditions. That this is the other things which I mentioned. Then if you talk about the state innovations, I have talked about the critical challenges. Let us briefly mention about the state challenges, state innovations. When I was in Niti Aayog, Nimhans has approached this, and Dr. Powell has been very upfront in giving direction to how to address the issues of the brain challenges. And after results of lot of deliberations between Nimhans and Niti Aayog, the Karnataka has come up with the brain health initiative, which has been a part of the primary healthcare system there. They are training the doctors, teleneurology is there, they're linking it with the Nimhans, so that the condition is being treated. As I've been mentioned that in that network, this is a model which is yielding results. It has been showcased as one of the best practices in the health system. Kerala is also having a strong public-private partnership. You take the example of stroke, thrombolysis, thrombectomy, is a specialized epilepsy movement disorders is there, dementia clinics are there. Apart from that, there has been focus on cognitive and behavioral neurology. So Kerala is also doing good on. Tamil Nadu is also, they're having this problem. They are focusing on NCOS, NABH, NCD management for improving the quality of services. And they are also taking a survey for the STEPS program. Besides that, you might have seen the program for embolism of the stroke patients. Of many of the states, they are doing on a pilot basis to address these issues. The technical, what we are doing at the apex level, we are a technical support agency to the Ministry of Health and Family Welfare, and we are supporting the states under NHM. Our mandate is to policy strategy development, technical assistance mobilization, capacity building, innovations, and knowledge sharing. We have been supporting the community-led programs across the country. That is ASHA program, community platform, village health and sanitation nutrition days, the comprehensive primary healthcare program. We develop operational guidelines, training materials. We promote quality standards, the Indian public health standards. We conduct implementation research and evidence synthesis. We are trying to focus explicitly on neurological condition within the NCD CPSC support, so that we can act as a knowledge broker for research translation. So these are the recommendations. I think we do have a two-pillar recommendation for this thing. One is to improve data systems, strengthen primary care, the policy, develop, implement effective healthcare policies. We do have policy in place. Time has come that the 2017 policy, which was made to address the SDG concerns, now we have to make a policy for 2047 Viksit Bharat. So we have to see that how we develop and implement an effective healthcare policy strategy to address this issue. Besides that, the other arm is the how to improve the governance aspect, how to address the workforce gaps, how to enhance the health promotional activities for this brain health and the neurological disorders. In these two arms, we are trying to work, and in the coming days, you'll be hearing more about that. And this is other things which we are. This is just an explanation of that. So that's all I think from my side. Thank you very much. And now we have to see that how in concludingly, I have to see that how the neurological disorders pose a significant this. We have to address these challenges to a holistic systemic approach. And these are the key levers which are available with the government. We do have a strengthened policy. We do have a governance framework in the form of Ayushman Bharat, all the four pillars. That is the Ayushman Arogya Bandi, PMJ program, Abhim program, the digital mission. We are focusing on improving the access and equity through increasing the two various modes for strengthening of the community health center, as well as bringing the specialist services to the Ayushman Arogya Mandir to e-Sanjeevani program. We are ensuring quality of care by adherence to the Indian Public Health Standards as well as NQAS certification programs, so that the institution through which we are providing services, they are of a good quality. Then we do have a best practice sharing workshops, national workshops with all the states, wherein very good practices of one states are shared with the other states, so that the message is clear. They can take back the message and see that if a particular initiative works in a state, that can also work in the state. We are trying to push for a collaborative efforts between the state and the central government, and we try to act as a bridge between them. And we are also trying to get involved with the research agencies, the professional bodies, and the communities, so that we can achieve an equitable quality care. I think this is the last slide, and any questions, I am there to help you. Thank you very much.
Thank you very much, Dr. Madan Gopal. It was exhaustive, and it is so enlightening to know that the government is on an extremely clear path. Also very enlightening to know that for a 1.4 billion population now, of the 14 lakh beds that we are going to have, it's almost 60% are in the public sector, and then it's still going to get enhanced in the coming years. And that's something which we really look forward to. If anybody has any question, kindly do put it in the Q&A. We have Pushkaraj Mane, who says, good evening. He's a co-founder of Manastika. I know him very well. He has got a tele-neuro rehab startup. He asked that the multidisciplinary neuro rehab is missing in most government hospital and still isn't covered under insurance. How can this be solved?
Bindu, as I mentioned, this is a good question, evolving question, because I've mentioned that the brain health initiatives are recently started. The Mental Health Act was in 2016. So it is getting implemented, because for implementing you have structure. First, the structures are built in, because the priorities now are, one, the RCH is the priority, the communicable disease and non-communicable disease, that is BP, hypertension, and the cerebrovascular accidents which do happen. So slowly and slowly, we are building in capacities at the district hospitals. We are trying to capacitate the community health officers at the Ayushman Arogya Mandir. But what I can say, that point is well taken, and still work is in progress. It's not that a ready-made solution is there. We do have a limited budget. In this, we have to prioritize our things, our activities, and see how we move in that direction. The priorities are that if somebody is having a stroke, we're trying to have a program for stroke. We are having a STEMI program. We do have a dialysis program. The whole focus of the public health is, if it is an important public health thing which requires significant investment, the program usually takes the upper hand. Slowly, with the Karnataka Brain Health Initiative, once it is integrated, where they are having a multidisciplinary setup for addressing this issue. Based on the success of that, let us see that whatever results are coming from that Karnataka Brain Health Initiative, that whether we can replicate and it can be adopted in the other states. That only with time we can take a call on that.
Absolutely. Given the neurological diseases where a spectrum of care is needed from prevention, acute treatment to rehabilitation, it becomes really challenging, unlike in other particular diseases. There's one more question that needs to be addressed is that we always talk what the government is going to do, but then I would like to hear from you that what responsibilities do the neurologists have beyond the patient care when it comes to advocacy and public awareness under national programs? It's time that we also look within ourselves and see that what best we can give back to the public and to the government, and what does the government expect out of a neurologist?
One thing is what we are doing. I will just talk from that perspective, layman perspective, not as a government policy maker. So I've been interacting with many associations, right from cardiologists to PSM people to neurologists and the critical care specialists. But what I always say that you look what the government is doing, because the scale will only come with the government programs. Whatever small things as an association you are doing, if you want the scale, you see that what the government is doing. You are all resourceful, very resourceful, having all the knowledge, but see that how the knowledge is applied in the given this situation, given health system and the structure. Whatever whatever suggestions which we are making in the guideline, during the framing of the guideline, we open the experts from the particular field. Whatever guidelines which we are making, see that how that can be replicated, adopted, and rolled out in the given situation, not in the ideal situation. Because when we are doing the skilling program also, we usually say that you have to simulate the labor room in the district hospital, not the ideal condition. Similarly, when we are making guidelines for the brain health and the other things, we see that what kind of situation would be there and what the person should be doing, because they can't be trained as a neurologist. But you can't be creating neurologists in medical college and asking them that they should be serving at the, because a super specialization means he has to invest 13, 14 years. After 13, 14 years, you ask him to work at a very low resource constrained environment, it would be difficult. But at least you can translate your knowledge, your skills to a person. At least you should capacitate him to what level he can treat, and where to stop and where to refer that patient. If that kind of boundary, if the associations and the neurologists are able to bring in the guidelines, I think that would be the biggest service, because it's not that we will be training everybody in the task shifting that you can do everything. No, it takes 13 years. You can't be teaching people in 6 months or 3 months. See that where to draw the boundary, when to refer the patient, how you can make the thing simple for the people to identify neurological deficits based on the experience and other things. See that how it can be identified at the earliest so that the person is connected to the system and we are able to help that person. If we are able to do that thing, I think that would be the biggest contribution from the neurologist as a specialist. Because how to translate, if you just go back to the medical college day, the basics things usually the professor used to teach, because he knows that what the student is required to learn. If a demonstrator comes and talks to a first year student, you see the plight of the student, he would be confused. But the professor knows that what is required, what a medical officer is required. We have to work in that direction. When the guidelines are made, we will be inviting all the people. See that you have to just visualize that what is the situation at the ground, and how in the given situation, what kind of work, what kind of extension, what kind of outreach can happen. You can't be Bindu, can't we have, we require at least 1 lakh Bindus, but you can't be everywhere. That kind of outreach efforts are required. You can't be everywhere. You have to see that what your learning, whatever you have learned, that is transferred into an outreach program, so that you create more and more people like you. Otherwise, it will be just an expertise. You will come, you will give an expert opinion, but it won't be translated into the ground. So that's the only request which I am making. See that how we translate the learning, the high level of knowledge into very common level of knowledge, which can be used by people like nurses, the doctors who are working in the primary health centers or the community health centers. At the district level also, even the neurologists who are posted there, they also require some capacity building initiative. Just focus on the neurologists who are posted at the district hospital, help them in at least in the CME program, so that they are also abreast with the latest knowledge developments in the neurological field, and they can contribute to the training as well as the execution of the program. The scale will only come from the government side. We see that how we leverage the expertise which is available here, that is translated to the simpler forms and taken to the outreach activities to be executed at the through the government infrastructure.
Thank you. Thank you very much for that insight, because that's very important that each and every one of us neurologists do put in our little bit share to see that whatever the government is trying to implement, we join hands with that. We have one last question here, and it's Govati Nikhila. She's a dysphagia specialist and researcher. She has also reached out to me with her project that she feels that the dysphagia care and the dysphagia services in any government hospitals or any of the private hospitals are not there. And she has come out with a project which is trying to address many, and she wants to reach out to at the government level as well. Govite, I suppose I would be going through it and will be reaching out with Dr. Madan Gopal as well, and look to see that how we can put it into the right perspective. I suppose this is one more important aspect, not only in stroke, in a general population and elderly population. Thank you very much, Govati, for reaching out. We will see to it that this is also placed in front of Dr. Madan Gopal. We have our second speaker. Again, thank you very much, Dr. Madan Gopal. It was extremely impressive to know what the government is doing. And it is also very important that we are also tuned to what is happening in the country so that we can align our activities in the same manner. We have a second esteemed speaker, Dr. Ramani, who currently serves as the president of the Asia Pacific Stroke Organization. Dr. Ramani is a very renowned neurologist and a leading voice in the field of stroke care, with significant contributions to advancing stroke awareness, research, and management across the Asia-Pacific region. We are truly honored to have his experience here. And Dr. Ramani is going to talk about stroke in the young, which is a growing concern in the Asia-Pacific. We all of us know about it. And let us hear from Dr. Ramani now.
Thank you very much, Dr. Bindu Menon, for your very kind invitation and for your very kind introduction to me. I enjoyed the lecture by Dr. Madan very much. It shows how in a country as big and as populous as India, there are clear directions from the government. There's cooperation from the healthcare people who are involved, and I'm sure you'll succeed very much in bringing down the disability and mortality from major diseases, including the issue of stroke. So I'll share some aspects of stroke in the Asia Pacific region, which I hope you'll find interesting for this afternoon. I'll give you a perspective on what's happening in the Asia Pacific region, and you'll see how a lot of overlap and similarity there is, and synchrony with what's happening in India already. And I really think that India has shown how things really can be done. I have no doubt India will succeed. I'll give my presentation under the following headings. After some brief intro remarks, I'll just present the Asia-Pacific issue of stroke burden and the trends over time, what the trends are in metabolic diseases and the burden in that, show some comparative studies of what's happening out there in the community, make a commentary before making some concluding remarks. Well, the Asia-Pacific region generally refers to this part of the world, much of East Asia, Southeast Asia, Australasia, and of course, South Asia. And let's not forget the Middle East countries, which actually are part of Asia too, but are often left out in many publications of Asia, Pacific, Asia-Pacific publications. Whatever it is, we all are one big family in the world. Asia Pacific has 4.3 billion people. Nearly 2/3 of the world lives here, with a wide range of socio-economic status. With many economic transition, many are transiting from communicable diseases to non-communicable diseases, having all the bad risk factors in the community, and therefore having more and more stroke and heart attack, sadly also among the young. Well, now the question is, who is young? You can define young as those below 40, below 45, below 50, below 55. But Dr. Mahathir Mohamad, who is a medical doctor, to let you know, he was the oldest serving state leader at the age of 92. So 90 is the new 30. So everything shifts, I think, when you look at biological age. But in research, we use chronology because easier to work with. Those who are young and who have stroke are a bit different from the older people who have stroke. They have the less traditional risk factors. They have hypertension, diabetes, hyperlipidemia, but because they've only had it for a shorter period of time, they're less likely to have atherosclerotic stroke. But sadly, smoking starts young, obesity, sedentary lifestyle does sadly raise the stroke risk among the younger people. Among the young also, there are different types of stroke compared to older folks. There's more rheumatic heart disease and embolism from that, dissection of intra and extracerebral arteries, migraine stroke and OCPUs, genetic plays a part to play, as to prothrombotic state, and in South Asia especially, venous thrombosis. You then look at the younger people, they're living much longer. And therefore, when they die earlier, they have more years of disability. The entire healthcare system needs to support them with medical, nursing, and rehab. They want to return to work. They want to have a family. They want to have leisure activities. They want to drive. All these are the challenges the young people will face with many more years ahead of them. Look at the social impact on the country, on society. They are important members of the workforce. They drive the country in terms of where we are going. So a loss of a young person to stroke is a real impact on not just the workforce, but a bigger strain on healthcare services. So long-term impact of stroke will be driven by what happens to the young. Let's look at the population structures to see what a big load the impact and illness of impact of young people will impact on the entire country. If you look in for example, here in Europe, it's a very slim pyramid where the young and the older people are not too different in numbers. And this is not too different in North America. As you go to Latin America, and certainly in Asia and Africa, the young people, whether you talk about 50 and below, 40 or 30 and below, comprise a large proportion of the population. And therefore, any illness affecting the young will affect a large proportion of that country. And that mustn't forget that as the countries with more young people will have a large effect on the healthcare services and the economy as a whole. Things are changing over time. In the post-war years, there were more younger people and a fewer older people by proportion. But this changed about 10 years ago. And in years to come, it will be a bit more structured, I think, in a more symmetrical, in a more rational, in a more physical manner, as more across the various age structures. But this is not the same throughout the Asia-Pacific region. Look at China compared to India. In the early years, you can see how over time, the Chinese population is getting older. There are fewer and fewer young people. But India is blessed with many young people. As you can see from here, as time passes, the young people will continue to form a significant proportion of the country and will drive the country's economy as it already has been. And therefore, stroke in the young in India have a greater impact than in China. So now let's look at beyond population burden and population trends. How about stroke? I think the best study that looks at stroke burden comes from the governor disease study. I'd like to share this one that was published not too long ago, just a month ago, on stroke among the young, and young defined as 15 to 39 years old. Overall, the number of stroke patients in the world that was young was nearly 750,000. The DALYs, which are disability, just life years lost, which reflects death, the effect of dying early, and the years of disability is also tremendous, nearly 9 million. And mortality, 120 million. So clearly, globally, there's a big impact of stroke among the young. But this is not the same throughout the world. If you look at the effect of incidence, death, as well as disability, it is not the same throughout the world. And elsewhere, the tremendous impact in Russia and as well as North Africa is different from what's happening in the Asia Pacific region. Look at how high it is in places like Mongolia, Pakistan, Southeast Asia, which are lesser impact in India, South Korea, Japan, and Australasia. And similar things are seen, how India has done actually extremely well compared to the other countries in Asia Pacific. But Southeast Asia, where I live sadly, has a tremendous burden. But Japan, Korea, Australia, Asia, doing extremely well. So some countries are having bigger burden than others. India is doing well, which is a tremendous, to your credit, of course. As you can see from this, over time, the incidence globally has increased by 19%. But despite the numbers increasing, the rate when you correct for the population numbers is actually falling. Because incidence, deaths, mortality, they've all been falling globally throughout the world when all taken together. But this is not the same in the Asia Pacific region. As I mentioned, if you look at the global percentage, it has fallen, as have the age standardized rates. But it's not the same in the Asia Pacific region. Yes, it's fallen in high income Asia Pacific. Yes, in East Asia. But unfortunately, in Oceania, South Asia, and Southeast Asia, the numbers have actually gone up. When you correct for the population numbers and standardized by age, it's actually fallen. So the numbers are going up in Oceania, South Asia, and Southeast Asia. And this number increase is what's going to strain the healthcare system, especially in these regions. Mortality has a similar lesson that globally, while mortality numbers may have fallen, especially in high-income Asia-Pacific, in Australasia, in East Asia, the numbers dying, unfortunately, are going up, especially in Oceania, to some extent in South Asia and Southeast Asia. But it's true, when you correct for the population numbers and age, the rates are actually falling, but the numbers are not. If you look at the dailies, this is a different format as you see from the other slides because it's from a supplementary file from the publication, but the message is the same. Similarly, globally, while we can see a fall in the dailies in some regions, especially in high-income Asia Pacific, as well as in East Asia, the dailies are rising in Oceania, rising in South Asia and Southeast Asia, while the rates are falling. So the message is clear. While the rates may be falling, the numbers are rising, largely driven by growing populations. As we know, stroke comprises three different subtypes. There's subacute hemorrhage, there's ischemic, there's interstitial hemorrhage, and there's ischemic stroke. And again, the pattern is different. While generally ischemic strokes predominate, the incidence is very high, especially in Pakistan, which you see out here, which is higher than, say, in other parts of the Asia Pacific, compared to Australasia and even China. Look at hemorrhage, and a similar pattern is seen of a discrepant burden of disease in different parts of the world. And Southeast Asia is carrying a particularly high load of ischemic stroke. So in Asia Pacific, things are different, and the numbers are therefore different as well. Sadly, the trends are also not the same. While incidence is falling in some countries, those that are blue show a falling trend, those that are red, a rising trend. You see that China is falling, but elsewhere it hasn't changed very much for SAH. For hemorrhage, and unfortunately for ischemic stroke, there's not fallen very much. So interestingly, in Korea, they've shown interesting, very nice falls. So they're doing something right. Koreans can teach us a lot of things, including how it is they make it do better for stroke, especially the falling of ischemic stroke and intracerebral hemorrhage. Let's now look at metabolic trends. While age is a big risk factor for stroke, so are metabolic risk factors, especially for ischemic and hemorrhagic stroke. Overall, the metabolic risks are sadly very high. If you look at DALYs, overall, across all the various diseases, you see how high it is in Mongolia, how high in Pakistan, how high in Southeast Asia. But wonderfully in India, in South Korea, Japan, Australasia, the metabolic risks, as measured by DALYs, is actually lower than, say, Southeast Asia. But it's not the same across all the metabolic risks. It's different how BMI differs in our part of the world, as high fasting plasma glucose, as cholesterol levels, as blood pressure, as dysfunction. So it's not the same that the metabolic burden is high in some countries and lower in others. And this can be due to very many reasons. If you want to look at the numbers, what's number one, what's number two? Here's the data among men and women. While globally, obesity is a big problem, hypertension more in males, maybe diabetes more in women, but they all comprise among the top 5 in both sexes. In different parts of Asia Pacific, different metabolic risk factors have different parts to play. In Australasia, high-income Asia Pacific countries, South Asia, which has a very high load of diabetes, which is rising in Singapore too, by the way. In Southeast Asia, East Asia, and the tremendous burden of diabetes and obesity in Oceania and Southeast Asia is not to be missed. So again, the metabolic burden is not the same in every part of the Asia Pacific region. It's not the same in every country. It's not in every part of every country. Again, we come to trends. The trend is not a pretty picture. The trend is about rising metabolic burden globally, whether it's obesity, glucose, cholesterol, blood pressure, discriminative function, taken together, it is rising in BMI and high plasma glucose is driving the trend globally. So you can see it's not a pretty picture that in many parts of the world, in Asia Pacific, while the rates are falling, unfortunately, the numbers are rising. Unfortunately, the metabolic risk factors are also rising, and the young are going to be unfortunately succumbing to stroke because of these various factors, and the healthcare system has to cope with them. Having looked at the general trend, let's look at some real hard data and some comparative studies. May I first share this study that was a prospective observational multi-center hospital-based study among young stroke patients aged 18 to 49 in Malaysia, Philippines, China, Taiwan, Thailand, Pakistan, and Korea. Well, I'm very happy that while India did not take part in this, there's a wonderful study published in this excellent journal which looks at stroke in India among the ischemic stroke as well in a very similar manner. And this is again a lovely retrospective single center study of consecutive papers that was just published barely 6 months ago. And I'm happy with this paper because very similar to the study I showed just now. And the message is very much the same. While this study that I've mentioned earlier, only 200 patients, the India study had nearly 600. But again, you'll see how the age is about 40. Males across all the studies predominate. A family history of stroke, so a past history of stroke may be lower in some countries and higher in the Indian continent. Hypertension remains an important risk factor, as does hyperlipidemia and diabetes and smoking, very sadly, and alcohol use. But different countries have a different experience, and therefore it's not the same across every country in the Asia Pacific region. But notice it's not 80%, it's not 50%, it's much less than that. So atherosclerosis is not the driving reason for risk factors in the Asia Pacific region. Cardioembolism actually is. Atrial fibrillation, rheumatic heart disease, as you can see here in India study, and ischemic heart disease are driving the stroke among the young. And this experience is seen also in other parts of Asia too. If you then look at other risk factors which are not atherosclerotic, you see how migraine, dissection also are important reasons for stroke, especially dissection. Let's not forget contraceptive use among smokers who have migraine with aura are an important risk factor for stroke among young women. Hyperviscosity is not very common, but not to be forgotten. And let's not forget vasculitis. Let's not forget Moyer disease, an important cause of stroke among young people in the Asia Pacific region and probably seen less among Caucasian populations. Among the stroke subtypes, atherosclerosis is uncommon, small artery disease uncommon, cardioembolism important 20%, but other determined causes are mentioned as important, like dissection. It's an important cause of stroke among younger people. And this is seen in the Asia Pacific region and certainly among the Indian studies. But sometimes there can be more than one cause, up to a third in the Indian study and a quarter in the rest of Asia. Sometimes it's high because we haven't finished all the studies or no cause is found. So what does this mean in the Asia Pacific region? Well, overall, Australasia has lower incidence because perhaps because of better healthcare systems and effective preventive measures driven by the government. The high-income Asia-Pacific region, again, high declines are seen, again, because of strong healthcare systems, strong healthcare initiatives, and improved stroke care impacts not just the older, but the young as well. So we must start young and try to help everybody in the country. Sadly, there are disparities in the Asia-Pacific region, mortality and deaths, with Oceania suffering tremendously with the highest figures. Again, obesity, hypertension, as well as the healthcare access restriction are challenges, especially Oceania and in many parts of Asia-Pacific too. If one look at escalation and the rising ischemic stroke rates, I think the transition, all the bad habits coming in, hypertension, diabetes, smoking, are going to drive risk factors and stroke among the younger people. So lifestyle changes, where too much sugar, as Mr. Madan has mentioned, Dr. Madan has mentioned, too much good food around, too much salt, too much smoking is raising issues among the young as well. Let's not forget air pollution, a big issue in China, many parts of India, and Southeast Asia, where exposure to these particulate matters are raising stroke risk. And these young people are going to carry this risk with them in the many years of their young lives. But increasingly screening, diagnostic measures in developed countries is going to enhance good detection of stroke and hopefully of the risk factors and prevent the stroke going to come. Being stressed, life is very stressful in many parts of the world, may increase stroke risk no matter whether you're rich or you're poor. And sadly, inadequate primary prevention, especially in lower economic regions, not just in a country, within a country, the more rural, the more financially stressed parts of that country will also suffer stroke because we cannot deliver adequate preventive measures to these regions. Those countries that have high rising trends, we must do much more to address the deficiencies in prevention, acute stroke care, and long-term rehabilitation. What are declining trends? We must not sit on in our laurels. We must remain vigilant, offer insights, and share our experience with others so everybody benefits and the global burden of stroke among the young and not so young can be reduced. And therefore, targeted preventive measures are crucial across the board, but especially in the lower economic regions where the burden is rising. Not just risk factors, but also must consider the cultural and economic, socioeconomic factors that determine and drive healthcare behaviors and access. Then, of course, as Dr. Madan has clearly mentioned, healthcare infrastructure has to improve. Money has to be put in, and people must know that they must come and access all these wonderful resources that are available. Only then can we reduce mortality, reduce disability, and by keeping the price down and not making people having to choose between buying food and healthcare, they can spend more time on their health. Those that have strong healthcare systems have clearly shown they can reduce healthcare burdens in their country, and stroke among the young is certainly something we must invest in. Dr. Mathis mentioned, we must have ongoing research that track the trends and the surveillance of whether what we're doing is effective. And research into what's happening in that country is important. Like venous thrombosis is a big issue in South Asia, and I'm sure that South Asia will show the world what we can do to prevent stroke, especially in this setting. So research clearly will help us do a better thing than we're doing right now. So, Madam Chairperson, some concluding remarks. We all are aware that stroke is a big healthcare burden, especially among the young, and the numbers are going to rise because of the rising numbers of young people in our part of the world. But it's disparate. Some countries will feel it more than others. We correct for the age factor and the population structure, the rates may be falling, but the numbers will rise. But because of different risk factor distributions, different financial distributions, the mechanisms of stroke, the subtypes will continue to differ. The disparity will remain. Not always socioeconomic factors will drive the risk. It's also behavior and infrastructure development and access. So we need more investment in this. We must monitor progress of healthcare among the young and everybody actually, and do more research. And India is clearly posed to show the world what can and should be done. With that, Madam Chairperson, I thank you and I'm very grateful for this opportunity to speak with you. Thank you very, very much.
Thank you. Thank you very much, Dr. Ramani, for this wonderful insight with the trends that you have shown. There are a couple of questions for you. So you just mentioned that the metabolic burden is not so very high in India as well, according to the global burden of disease that was depicted in the graph there. So are we looking at any unique genetic or environmental factors? So are we looking at air pollution or some genetic traits which are which we are probably missing out, which is leading to this increasing trend of stroke in young?
I agree completely. While it's true that the metabolic burden may not be that high now, as they live longer, it's going to come as the population becomes more wealthy and they're spending more on healthy food, smoking more. The metabolic burden will rise in India and in many other countries too. But you're right, pollution is a big part to play, as has smoking and genetics. And therefore, we need to look very hard in each country, in each part of the country, what is driving stroke there. And in India, sad to say, pollution is an issue. I am aware of that in rural as well as cities. We need to do a lot more to battle pollution in India, China, and other parts of the world too. Genetics is often not looked at. In Singapore, we are afraid to look at genetics because insurance companies will refuse to cover people with genetic diseases. So genetics is a double-edged sword. And right now, we can't quite treat genetic diseases in for many of them. And therefore, sometimes while knowing is great, if we can't treat them, maybe we should just hold on first, except for more academic reasons. Don't search for genetic causes, but search for things we can do something about. And reducing salt, reducing smoking, combating pollution are things we must do a lot for, especially among the young who have a long life ahead of them.
So prevention still remains the key, because from the spectrum of care and stroke, prevention does remain the key. According to you, what do you think is a primary prevention strategies would be most effective in reducing this burden and stroke in young in our country? Now, how could we better screen young people, because they are a different generation which refuses to, though the Ministry of Health and Family Welfare says that 35 and above needs to be screened for hypertension, diabetes, and lipid profile. Do you think schools, workplaces, colleges should be included should be starting to include that they should have as a curriculum their blood pressure, their sugars, and the lipid profiles checked, because we are seeing more and more younger people getting affected, and that is where the brunt is. Maybe the BMI as well, and give them a health card that as to where you stand.
I agree entirely. We must start young. In Singapore, you cannot buy fizzy drinks in schools anymore. There's too much obesity. Just it's not available. You cannot buy a cigarette if you're below 18 years old. So by doing that, we're already restricting access to some of these things. You cannot vape. You cannot have shisha anymore either in Singapore legally. So by reducing access, it's one thing you can do. And you're right. By having health screening early, it's important. If the school nurses or even the staff can start checking blood pressure even once a year, looking at obesity rates, BMIs. It's a good place to start by raising awareness. And by keeping the cost low, they have no reason not to do it. Unfortunately, the young think they can rule the world. Oh, they will, no doubt about that. But we're not invincible. As long as we don't arm ourselves with good health, we cannot fight the long battle. A business factor stroke is stress. People are dying from stroke. Korea, Japan have shown us that stress and working too many hours, like too many doctors, nurses, we work too many hours, are driving our own deaths. So we must start young, raise awareness at the young, and continue to provide a facility for them to come for screening, reward them if needed, and also to ensure that they don't have to pay much for their care. For example, the poly pill, which India has done a lot of work on, comprising a small dose of statin, a small dose of a blood pressure medicine, and maybe an aspirin for those who have heart and stroke disease, has done tremendously well in driving down the occurrence of stroke and heart disease. Something as simple and cheap will make a big shift among stroke, not just among the old, but among the young as well. But the whole healthcare system must come together to work. And Dr. Madan has shown very nicely how India is working towards this model. And by expanding it to the schools, to the polytechnics, the universities, it's a great place to start. Well, the old people know, the young people need to know and to buy into this. Thank you.
Add, I think your school point is well taken, and there are few pilots going on. Niti Aayog has carried out the piloting that how to reduce the obesity and the screening of the school children. So that program is there. Now you will be increasingly seeing about the counselors and the medical nurses being stationed at the school so as to take care of the needs of the school children. So that means the thought process which is there, and few people are also in the government thinking about that, and we are trying to roll it out. Let's see how the pilots and other things they become a reality and it becomes a part of the bigger national program. So that is still work is in progress. Let's see the results of that.
So in the schools and colleges, unfortunately, now it is driven by competition, and the timing of the schools and colleges, especially the schools, are from morning 7 a.m. to it's a 12-hour shift. So it is hardly impossible for especially in the place where I am, I should say that implementing that and going and giving, when I go to my school and college campaigns, it becomes difficult for me to impact upon them that exercise is
Maybe
essential.
when the usually do happens in the initial there will be resistance. Say
Yes.
that it can't happen. The moment the results are obvious, then people will start falling in line. They will
Yes.
obviously it will come into the stream. Otherwise, you see the STEMI and the other thing. It was reluctance from the
Yes. Yes.
system side. Now, after demonstrating that it's quite doable. That is the early initiation of the thromboembolic therapies that is yielding results, that is saving lives. You see, the adoption and the adaptation of that thing is increasing. And many state governments are coming forward and trying to build into the system. Tamil Nadu, you see that immediately some symptoms are there, immediately that the prescription which is there, it is immediately given without waiting for the doctor to come. That is a no harm for everybody. It would have a, if some stroke is in evolving, then always you are able to save that person. In the school program also, I think let's wait. Things will evolve. If the people start seeing value in that, I think it will become a major national program.
Absolutely. And I think the adaptability of the students and the teachers, including the parents who are forcing them to read more, would also be there. Thank you very much to both my speakers today, Dr. Madan Gopal, for giving an excellent overview of the health conditions and the perspectives in the country, Dr. Ramani, for giving us a beautiful insight into the stroke in young, and also making us aware that there is a lot to be done, and individually as also a neurologist workforce, much can be given. Thank you to all the participants who have joined us on a weekend for this webinar from the Outreach Indian Academy of Neurology Outreach Subsection. We would be coming out with more of these webinars, hoping to have you more in our future meetings. Thank you very much. Have a beautiful weekend, all of you. Thank you so much.